Hey everyone, it's Dan and Don. Welcome back to the clinicaltrialsguru.com.
Oh,
We've got a fantastic guest for you today, Mike Moore. And Mike is a med student. After being a physician assistant for many years, he's now a med student working at a hospital in the greater Seattle area, and he's going to tell you exactly which one. He's got tons of stories, tons of experience in clinical trials and healthcare related issues. He's also pretty involved with social media. That's actually how I met Mike, through a Twitter chat that they call HCSM, which is somewhat entertaining on Sunday nights. Uh,
so you guys got nothing better to do.
we got nothing, like when I'm watching Sunday Night Football, I'll just use my iPhone and put in HCSM,
And there's always something there that you
always
will grab your attention.
they even do pre-game and post-game shows. If it's entertaining, I'll jump in. If not, I'll just read as I'm watching
Okay.
some football teams go at it. But Mike is here nonetheless. Mike, introduce yourselves. Tell us a little bit about what you're doing now, and then a little bit about your past.
Thanks, Dan. I guess to start off with healthcare social media, I kind of have a rolling series of taglines that I used to introduce myself to healthcare social media chat, because healthcare social media chat is it's kind of an amazing group of people, because you have people that are clinicians, you have patients, you have administrators, you have payers, and we're all throwing these things back and forth all the time. Just exactly what Dan is saying. It's just amazing the ideas that come out of that, because you got the three main people: the people who do the care, the people receiving the care, and the people paying for the care. And they all have three perspectives, and they never talk to each other. The patients yell at each other about the doctors and the payers yell at each other about, the patients and the doctors, but no one ever gets us all together in the same room. And that's exactly what healthcare social media chat is all about. And when I introduce myself there, I basically say, I'm a third-year medical student with a past,
Okay.
because I started off as an infantryman in the Army back when I was a kid, and then went to flight school after that, was a Cobra pilot and then a medevac pilot. And then about 20 years into my Army experience, I decided that I was going to be a PA, because I figured that would be a nice job that I could do. I was relatively fit. I kept myself, kind of trim in the military sense. And then 9/11 happened, and I found out the busiest part of my career was really ahead of me, not behind me. And been deployed to Iraq, and then when the Army decided in late last decade to send me to a doctoral program, I just said, well, why don't you just send me to medical school? And they said, fine, prove that you're 25 physiologically, pass the physical without any waivers, and we'll throw some more money in you, and that's what I did. So
Good.
right now I'll be going back on active duty in the summer of 2013, and I will be a 50-year-old intern at this juncture.
Man, hats off to you. I mean, to prove that you're 25, I couldn't even do that when I was 25.
Well, one of the great things about the Army is that, maybe not so much in the 80s and 90s, but now we really do try to focus on keeping people healthy, because healthy soldiers are happy soldiers. They can better adjust to stress and all the crap that we put them through in Iraq and Afghanistan, have more stable relationships. And then we also, just being fit is, you can't walk around with 60 pounds a year outside the wire, if you're a Marine or a soldier, without being fit. It doesn't matter if you're 18 or you're 28 or 38. We all kind of have to meet that same standard in order to deploy. So I think we practice some of the things when it comes to chronic health care, with some of that. The other thing that I really have a passion for is, taking care of psychological problems, taking care of stress, all the other things that come, all the crap that comes with, just having an active life, a real life, and taking care of that for soldiers without them being embarrassed or feeling like they're weak for accepting mental health care. And the Army has been really good about that in terms of like generals stepping out and saying, and colonels and sergeant majors saying, hey, getting deployed 3 or 4 times, it's hard on you. And I've had to get some counseling. So as a private or a sergeant or as a lieutenant or captain, you shouldn't feel bad about that. So those are some of the things I'm really passionate about.
Are you seeing, you've given me a lot of things to go through my mind, a lot of questions here. So I'm going to back up to at least the first one here. So with this social media healthcare site that you got going, so this is a chance for both the patient, the clinicians, and everybody to talk about what's really going on as far as payer sources and how the payer sources pay for treatment, or is it just strictly about treatment between the patient and doctor? What's happening there?
Oh, and that's an awesome question because really, we overuse the word meta a lot, but this really is. It's really a lot of people talking about a little bit bigger issues. We don't really get into specifics, but what we do talk about are things like, for example, what is appropriate for a physician to share about their personal life in social media, and what you think about that, what do administrators think about that. We have the AMA who says, well, okay, everything you post on social media has to be squeaky clean, like your, Marcus Welby. But you know what? Marcus Welby is dead, rest his soul. Doctors, nurses, other healthcare providers are real people. Are you going to tell them that they can't, no one can take a picture of them drinking a glass of wine?
Right.
What does that mean? So that would be a good example of the kind of discussions that we have, The other thing is just especially the people that I really enjoy interacting with on healthcare social media chat are the patient advocates who are really leading their patient communities to try and get outstanding healthcare. And that's really, just with the clinical trials that you guys work with, that's really so important because those empowered patients can really be the people who mobilize interest in clinical trials, who are engaged. Sometimes they're even more engaged than the physicians are, or the people working with the clinical trials because they're looking for new ways to approach their disease. They're looking for new answers, And I think over the past 3 or 4 years, people have gotten a lot smarter in terms of just because it's new doesn't mean it's better. That we need to figure out good, efficient ways to use the tools we already have. Does that make sense?
Yes.
We have a new drug come out, for example, or we have a new device come out. Is that the best thing for this patient this time? And I think patients, instead of just wanting the newest and bestest, they really are, patients are getting a lot smarter about what works for them and whether or not they want to jump in to do something new. So the empowered patient community is so vitally important for the progress of medicine now,
Absolutely. We've had e-patient Dave on.
Oh, awesome.
Yes,
He is amazing.
Yeah, he is. We had him on about a year and a half ago.
It's one of our first interviews.
One of our first
Right.
guest gurus, what we call them. And you know what? This e-patient stuff is real because I'm not making this story up. But last week, I had a former, not coworker, but he used to work in the same building I worked in. And he knows I'm involved in clinical trials. So, we've been, just kind of talking, casual talk, I didn't see him for like a year or two. He came to the clinic, and, I was surprised to see him. He said, hey, can I talk privately with you? I said, sure. He said, I know you're into clinical trials and all that. They discovered a tumor on my brain that's connected to my eye. And I've only got like 6 months left to live if I don't do something. And I don't want to do chemo. And I said, man, obviously I'm not a clinician, but you need to learn as much as you can about this condition. He didn't even know what it was called. He didn't, or else I would have looked for clinical trials for him. But I said, you've got to, he was kind of numb about it, which is understandable. But I told him, you've got to, start researching this stuff and start looking at, trials, if that's what you're interested in, or treatments. Don't just take don't just take the first thing that the doctors tell you, but do your homework. And I told him about e-patient Dave, and hopefully he's going to do it. I haven't talked to him since then. It's been a week. But it just goes to show you that these things are real. They go on every day. And, it's a little bit of our job to kind of let them know that they need to be doing these kind of things because the resources are out there.
Mm-hmm. Absolutely.
Right. Well, and they need to, people need to start doing it before they get sick. Just like you need to have a healthy body as long as you can, you need to kind of have, you need to be engaged with your own health before you get sick. Because, that's not the time to figure out, okay, what's the smart thing to do. And I think that that's one thing that is going to be the really transformative thing that happens over the next decade is what we're going to do is try and get that more upfront. So we're not waiting until a crisis, but we're doing it, when I have a visit, I'm going to have a suite of information that I give the patient, and it's not going to be something I hand them because it's wasteful and it goes in the garbage. It gets lost. It needs to be a place where they can look at their landing page, whether that's Facebook, whether that's whatever comes after Facebook, or whether Facebook becomes the Google of the next decade or whatever. They go to one place, they click on it, and they go like, okay, this is what I need to know about me. And then, oh, by the way, my pocket pedometer or my pocket activity monitor is giving a report in. Can I tell my doctor how many steps I took that day? What was my diet like? Those sorts of things. And the flip side of that is they'll be able to look at my profile as a physician and go like, damn, Doc Moore is, 52 and he ran a marathon last month. Well, maybe I can run a 10K. Maybe I can go to the gym, and I think there's a big benefit from that, because, one thing, like, for example, I've run 10 marathons or 11 marathons since starting medical school a couple of years ago. I mean, it's one of the things that I do. And when I stopped running, my Marathon Maniac friends on Facebook, on Twitter, they asked me, you haven't posted a run in a couple of weeks. Is everything okay? Did you hurt yourself or something? But that's great. That's exactly what we need, That's what people need. They just need a little bit of prompt, a little bit of encouragement. If I go to Red Robin a couple times in a row, there will be someone out of my 7,000 Twitter followers who goes, I thought you were a doctor. Do you really need to go to Red Robin that much? And yeah, maybe it is a little bit intrusive, but the reality is, hey, maybe you need to get called when you get the crunk badge on Foursquare or something. I don't know. It's just a thought. That's kind of a big picture thought. Maybe that is a little meta.
So preventive medicine is going to be the push then?
I think so. Preventive medicine, and not just preventive medicine, but healthier lifestyle. I think one thing, the United States is a little bit of a paradox because we have some of the best health, or some of the best medicine in the world. Mm-hmm. We have the best interventions. We've got the best medical toolbox in the world, but we have not anywhere close to the best healthcare in the world. Mm-hmm. And what we need to figure out, it's kind of like, what we basically do. I mean, it's like we all have Mercedes and we drive them and never maintain them. We've got to kind of figure out a different balance of what we do. I mean, otherwise, we can't just continue to spend 50% of our GDP on healthcare. We need to educate people. We need to do so many other things with that money, because, other than, just spend it catching up for decades worth of poor lifestyle choices. And that being said, I think one thing that we need to do is take the whole blame game out of that because, I still see people in clinic that start smoking in their 40s and 50s where, not in their 40s and 50s, but in the 1940s and 1950s, where there were magazine ads of doctors smoking saying it's good for your cough. So, I'm not going to go in there and, blame someone with a 65 year smoking history and, for something that clearly wasn't a problem or something that they didn't necessarily create themselves. Right. I don't know if that makes any sense or not. So,
I understand.
Now, how does all this that we just kind of talked about play into clinical trials? Where does clinical trials fit into this overall picture?
Well, and that's something that we really need to grab onto right now because, first of all, I think we need to be open to the idea that we need to do clinical trials not just on a new drug, a new device, but we need to figure out new ways of working with patients, working with providers, and working with administrators to say, not just this drug works better, but this system works better. dive into what, like, the reason why Minnesota is doing such a great job with their healthcare system and regulating healthcare costs. I don't know if that makes any sense or not. We typically think of clinical trials just being, okay, I'm going to start this person on lisinopril, and I'm going to start this person on placebo for the heart failure. One group's going to do better, one group's not. So I'm going to come up with a new indication for a drug, or I'm going to come up with, a new drug or a new processor. What we need to do is get out of, expand. Of course, we're always going to need that from clinical trials. What we need to know is what systems work better as well. We need to have an openness of, not just the specific intervention, but how do we get patients more compliant? How do we get them more educated? How do we get them more integrated into the healthcare system? And I think that's really something that we need to focus on, because that's our real weakness in our healthcare system. Not all the great things we have. We have tons of great, technology. What we don't have is the human technology of helping people get better and be better, with their health. I don't know if that makes any sense or not, but that is my, if, you go through the whole Stephen Covey, thinking about what people are going to say about you after you die, that's what I want to be a part of, is not just, I think the new big intervention is just going to be, it's going to, getting people to think about their health like hand washing.
Okay.
A century and a half ago, doctors didn't wash their hands because the doctors patients would think you're dirty if you had washed your hands all the time, and it took decades and decades and decades of observational science to show. I mean, if you ever read the story about Semmelweis and him, the guy who came up with the idea of washing his hands after deliveries to prevent people from dying from sepsis, he was so ostracized by the medical community that he committed suicide.
Wow.
So basically, or he drank himself to death or something like that, And, it takes a lot of courage to kind of like step back and say, hey, what we need to do is think outside the box and not just think about all the great technology we have, which is fantastic. And clinical trials has given that to us. But what we need to think about is how do we build a clinical trial for, a social intervention or a behavioral intervention. And we haven't cracked that nut yet. I think just because we haven't thought about it a whole lot,
Do you think we need to push to get society more involved in clinical studies?
I absolutely. And it's more than just involved. I think it's something especially, and you guys know this more than I do, is that there's so much of the data, when you look at a clinical trial, so much of the data is restrictive in terms of you have to control so many variables. By the time I'm looking at the results of a clinical trial in the New England Journal or Annals of Internal Medicine, I have a patient with 4 or 5 comorbid conditions or several other things going on or don't fit in those nice, neat little categories. I don't, it's hard for me to know exactly what to do with that information. Does that make sense?
It does.
And so I think that one thing that we have to do is we have to figure out a way to drill that desire for research down to the community level, to expand it as much as possible, to make it as part of the everyday practice of medicine as you can, so that you guys are collecting data from a lot of different, from a lot of different situations, so that someone can answer the question of, okay, yeah, I've got this person who's got, initial stages of congestive heart failure, and he's got hypertension, but he's also got comorbid conditions X, Y, and Z. Does it make sense for me to start him on this medication, or how should I manage this patient? And then when you throw genomic medicine or personalized medicine into the mix, that's just going to, create an even greater need for that. So, I think, one thing that we need to figure out how to do is how do we integrate information about clinical trials, conducting clinical trials, integrating into clinical trials, all the way down into the community physician as much as possible. That would be, that would be my sense of the future of how important that is.
I think that is a challenge. It's just trying to even getting people to look at clinical trials as sometimes it's an alternative when if the status quo is not working.
Right.
Yeah.
And think about that further on down the line. When you're, that's, I think the problem now is that people don't think of clinical trials until they do it as a last resort, if that makes, and a lot of times the horses, the proverbial horse is out of the barn, it's kind of like, yeah, we're doing it. Not only are we not getting a lot of data, from that situation sometimes, but we might not be intervening and helping with the patient. Instead, if we, and I think that's again where patient empowerment and collaborative medicine really comes up front, because if you've got a truly empowered patient, they're going to be thinking of day one, from day one, what can I do differently to personalize my care, as opposed to when they're in the hospital for the third time with their end-stage disease.
Right.
So
that makes a lot of sense.
So I think that that's something that, and the bottom line is that, we've got to integrate that into, we've got to integrate that into the basic medical training and for everyone, not just the medical scientists that are MD PhDs or DO PhDs at the academic health centers, but it really needs to be a basic skill for every physician.
I like this topic, and I think I'm going to call it the problem with clinical trials or something along those lines. Now, Mike, I agree with what you said about how we need to do more studies on whether some systems are working, not necessarily focus on the medication, although there's always room for that. But who do you think should be responsible for doing that, and then where will the funding come from? Because the pharma companies don't want to hear anything about that.
Exactly, and that was and that's actually that is a fantastic question, and it's very insightful. Because do you remember a few months ago there was a controversy about Medicare calling doctors to see whether or not they accepted Medicare patients. Do you remember that?
Mm-hmm.
And it was, and then of course, just like anything else, it turns into a great big, Obama bash when it has absolutely nothing to do.
Yeah.
But the reality is that, here's part of the thing. When you dive into that actual research project, the research project is not really being done necessarily always within the medical community, but it's being done within behavioral sciences. It's being done within maybe psychology or sociology. And I'm not saying anything about those disciplines, but they approach research from a completely different point of view, that the kind of rigor that you see in the clinical research community, And I think I guess that's really my point is, that's where you really need that kind of research. That kind of rigor is applied to that research that comes from the clinical research community, as opposed to maybe some of those other non-medical communities that do that. Because and the other thing is that this is something that really needs to be addressed within. I think it's really a medical infrastructure issue, and it really needs to be something that has to be addressed through the national institutes, the National Academy of Sciences, type of level of research. Because just as you said, it's not going to make money for pharma. It's going to make money for pharma in the long term because we're going to be more effective and more efficient in how we do stuff.
But it'll help all of them instead of just one or two. And
exactly. And it's going to create a better environment because, long term, the true way forward is going to be the pharma approach, the therapeutic approach, as opposed to more invasive approaches. And all of those things are heavily weighted towards pharma. Those are, in terms of their long-term viability as a business. It's the Lipitor, the Zocor, those type of interventions are going to be the ones that are most bang for a buck long-term in the maintenance of health of populations. So, creating an environment where we know what works is just going to make it better for pharma, but it doesn't really relate to a specific drug or specific profit center that they can point to. So that's something that I think really has to be funded at the national level. It's basic research that we haven't done. So
yeah, and speaking from a research clinic's perspective, which is what Don and I do, with Southwest Clinical Trials, we would love to do this because it's, for us, we're looking at income, making income, and it doesn't matter if that
Right.
income is from a drug company or from a state or some government that wants to run a study. We'll be just as happy to do the two studies. So I think ultimately, yeah, it is a decision that will come from higher up. And are you optimistic or are you pessimistic?
Well, I'm generally optimistic because, for example, if you've read Atul Gawande's The Checklist Manifesto, I mean, it's if you haven't had a chance to pick it up, it's basically a book about a very simple intervention to decrease operative, basically problems during operations. Just the simple act of having a checklist to make sure the patient is tied down, the patient got scrubbed for 5 minutes, all of those things, and basically, at Harvard they bit the bullet. They did something that was like non, it's not a device, it's not a drug, but they did a clinical trial based on that, and they found that the results were, so much, were dramatic. So I'm optimistic that we're going to be able to do that because there's so much bang for the buck in terms of, and I think the real thing is, and maybe this just kind of came to me, was this gets tied into the meaningful use of electronic medical records, because this is really what we're talking about. When we talk about meaningful use, we're talking about using the information at the right place at the right time for the patient, but we don't have a good way of quantifying that. And maybe that's an open place where health systems are going to want to prove that they have meaningful use. They've got to prove that to Medicare, so that's going to be something they've got to pay for to get that done. So that right there might be a crack that an organization could jump into and say, hey, let's structure a small thing to say, okay, having this diabetes checklist actually improves outcomes for your patients. You're meeting a couple of Medicare goals by making sure that your A1Cs are below 7 in your diabetic patients, plus you're demonstrating meaningful use. And it's something you've got to do from a regulatory payer point of view. But let's build a study that we can publish and get that information out there. Of course, someone is going to have to pay you to do the data collection, to do the management of it, to make sure that it's reviewed by an IRB and all of those sorts of things. But does it make sense? That's a place where you can easily get your foot in the door and kind of say, hey, this is an effectiveness study, but what we're really getting at is Medicare, Medicaid, meaningful use of EHRs.
I guess the financial part's always going to be the hurdle you have to climb.
It is,
Yeah.
and that's what I'm trying to think of in terms of 'cause, I mean, you can come up with all the greatest ideas in the world, but the reality is that in the end it's got to come out of somebody's paycheck, and it's got to be paid for. And I think that's the hardest thing for us, is just making sure that we understand that, but that's a useful tool. That's not necessarily bad in itself, because things should pay for themselves, because there's so much extra expenditure in the system that, there's money in there to get things done. So
Now, Mike, as we shift subjects a little bit, I just wanted to get your thoughts, and maybe you can give us some advice to someone out there who's considering a clinical trial for the first time. Because we try to ask all of our guests the same question at some point. Let's say someone out there is watching and is on the fence about joining a clinical trial. For whatever reason, what would you recommend as a PA and a future MD? What would your advice be to that person?
to a patient or to a provider? Getting involved in one, or for the patient being
for the patient
considering one.
Yeah.
I think the first thing that if I would owe the patient is to research it myself a little bit ahead of time. I think first of all, constantly discuss with the patient that's got a condition that I think is going to be open to the application of a clinical trial. I think the first thing is that as a provider, you have to know what's out there in your local area, and also what's available within the groups of patients that you take care of. And then I think, especially for patients, getting involved in an e-patient community and helping them guide that through that process, because you have patients that come to you at all levels of ability to deal with, social technology. So, make sure that they're involved with it. Make sure that they're discussing it. Use a combination of online and printed information, and then follow up with them, on an ongoing basis. And make sure that you document it so that other providers that see them know what you're thinking about, in terms of getting them involved or getting them working with a clinical trial. So part of it is provider knowledge of what's going on. And I think a lot of people, once they kind of get out of training, they don't think about what's available in their area. They don't know about, for example, the clinical trials that are involving PTSD, for example, in my area that I'm particularly thinking about. Know what's going on. Know what's available in your local medical community. And then the flip side of that is discuss it early with the patient, and make sure that you empower the patient to go and look and bring stuff that they found on the internet that you could talk to them about, because I think that's the biggest thing is that people surf the internet. They do it in a vacuum, and they get that information, good and bad, about clinical trials, and then they try to make their own decisions. But if you tell the patient up front, hey, listen, I think that if you find something new, bring it to me. You're going to help me learn, and I'm going to help you understand it. And it's a two-way street. That's what you have to do with the patient. And I think you need to be open to that and discuss that with them up front, so they don't feel like they have to ask your permission to ask about it. Does that make sense? Because I think that's what we get into with patients a lot of times. They're afraid to bring you something because, they're afraid that of your reaction if you show them up or something. And,
I like it, man.
Empower them up front with that and say, listen, there's nothing wrong about asking me about this. Because I may know about it, or if I don't know about it, I'm sure going to want to know about it if you mention it to me. But don't get in that relationship where you feel like I'm the person who knows everything, because there's no way you do, because, the only person who knows everything is Gregory House. And number one, he's on TV and he's not a real person. And number two, he's such an asshole. No one would come see him anyway. So, you have to be a real person, be approachable, and validate their desire to question, is a clinical trial right for me?
I like that. I like that bit of information.
Mike, could you be my doctor when you finish med school?
Oh yeah, actually, yeah. Hopefully in a few years I'll have a virtual practice on HealthPath, and
very good.
Yeah, exactly. You'll be able to stick your arm in your computer and
Hey, why not?
There.
Why not? Take a blood pressure cuff and connect it to your computer and let it give you the readings.
Yeah, that's true.
Yeah.
But I think the thing is that there's lots of great things technology do, and then there's nothing that really replaces the human touch either.
Yeah, it's like having
kind of a mixed bag.
It's like having a Twitter chat with someone versus going to lunch.
Yeah, exactly.
You can't compare the two.
You can't compare it, but you know what? The great thing about Twitter, and we got off on a side about this in healthcare social media last Sunday, was I think people's personalities come through. If you're a dick on Twitter, you're probably a dick. I really hate to say that. And I kind of like, I don't know if you ever heard of Wheaton's Law. Will Wheaton, the Wesley Crusher from Star Trek.
No. Maybe Don.
He's got a huge Twitter following, but he's got of course, if you remember the old Star Trek: The Next Generation, people would be, pissed off at him all the time because they were like, you're just this, whiny kid that's on Star Trek, and people would take it personally, his character personally and stuff. And his response is, and he turned it into his, Wheaton's Law is, don't be a dick. And that applies to so much in life, and it applies on Twitter, and you can't fake it, At some point, people will figure out that you're really just not that nice of a person. So
it's true, man. Yeah, I'm trying to convince Don to start using Twitter. See, I use Twitter to post blog posts.
Mhm.
I know everyone says, use Twitter to engage with your audience and this and that. But when you have a clinical trial audience, there's only so much that people want to engage you with. So
Exactly.
I use it to actually recruit guests for our show, and I use Facebook for that too. That's how I got Mike on the show. I even admit it when I get on HCSM chat. I say, hey, I'm here to lurk and to recruit for my blog.
Right.
Uh, but I do enjoy reading the dialogue, and if it's interesting, I'll jump in. But there's so many uses for this that I'm encouraging Don to get on, and Mike
Yeah.
will do the same. You should join us on HCSM chat. This guy Don is a much nicer guy than I am. So that would translate. That would translate so well. That would translate so well on Twitter.
You think so?
I think so.
Yeah,
Man.
probably so. It
I
always
think
does.
so.